And now I'm pleased to welcome Dr. Vineet Chopra. Before I introduce him, I want to also thank him for being here today. He was not our intended speaker, but unfortunately our intended speaker had an acute issue arise. Vineet was willing to step in with less than 24 hours notice. And when responding to, can you give a talk tomorrow? He said, well, my flight doesn't leave until 3, so yes. So Vineet, thank you very much for being here. Dr. Chopra is a professor of medicine here in the Department of Medicine, where we also know him as the Robert W. Schreier Chair of the Department of Medicine. He is also an adjunct professor of medicine at the Griffith University in Queensland, Australia, as well as an adjunct at the University of Michigan. Make sure that works for you there. As well as, there we go, being the co-director of their health sciences research unit. He did his medical school and undergraduate training at Grant Medical College in Mumbai, India. He did his residency at Mount Sinai School of Medicine in New York, where he was also a chief medical resident, and did advanced training as a Master of Science and Health Sciences Research Fellow through the Robert Wood Johnson Scholars Program at the University of Michigan, as well as additional coursework in human factors engineering, also at Michigan. He really has dedicated his career to improving the practice of medicine and the outcomes it achieves by focusing on the process, how we do what we do, why we do it that way, and then how and why we should consider changing what we do. Straight out of residency in New York, he accepted the role of medical director and physician lead in Hot Springs, Arkansas. Within 2 years, he was their chief quality improvement officer. From there, he took those successes to the University of Michigan, where he won the Innovations Award from the Society of Hospital Medicine in 2009, Clinical Translational and Science Award in 2010, the 2013 Society of Hospital Medicine Young Investigator Award, and the 2014 Frank J. McDevitt Award for Excellence in Clinical Research. His work is focused on patient safety and outcomes, notably around access devices, which is what we'll be talking about here today. He's currently funded by several grant mechanisms, one in R18, where he is the investigator as well as a co-investigator, through one in Australia. Again, truly a world's expert on quality and safety. He currently serves as a member of the steering committee for the iHope Patient Engagement Project through our PICCs. He is the chair of the Products and Practices Work Group, the Department of Healthcare Quality and Promotions through the CDC. Also through the CDC, he is the co-chair of the National Health Safety Data Design Working Group and is a council member of the Society for General Internal Medicine. His work has led to a remarkable 262 publications. I think as I discovered that, I also discovered that we were the same age, and I felt very lazy. And over 100 inviting speakerships. And as an educator, I just want to mention, I know you get a lot of credit for your work in safety, but a true commitment to education. Dr. Chopra was the 2016 H. Marvin Pollard Award for Outstanding Teaching of Residence in the Department of Medicine at the University of Michigan. In 2016, he also won the Richard D. Judge Award for Medical Student Teaching, also at the University of Michigan. And in 2019 was nominated for a Golden Apple Award at Michigan. Pollock told me that I had to stop at this point because she has to live with you after this introduction. So I want to go ahead and welcome Dr. Vineet Chopra, our chair of medicine.
Thank you, Dr. Connors. Very kind. Good afternoon. Nice to see familiar faces. For those of you who are here, whatever you ask for, I will grant. For those of you who are not here online, I can't see you, so no requests are going to be granted moving forward. It's my pleasure to talk to you today. I'm actually glad this opportunity came up because this is a topic I've been thinking about for over a decade of my life. And this is a topic that's very relevant to where we are at UC Health in our hospital. So I've been thinking about this question is, are peripherally inserted central catheters or PICCs the central venous catheter of the future? Jeff already mentioned several of my grants. I'll also disclose that I do receive royalties from UpToDate for work that I've done there and for visiting professorships. I'm a proud employee of the University of Colorado, also an adjunct faculty at Michigan. And I will not be talking about my intellectual property, which is around tracking catheters in hospitals. We came up with this question of, if Amazon can tell you how many boxes are on a shelf, why can't you tell me how many catheters are on a floor? Simple question. So we've developed a technology to talk about that. I'm not going to go there today. I'm going to begin with a clinical case, which is a true story of someone I saw many moons ago as I started thinking about this work. And this is a 68-year-old male with the typical medical comorbidities who had a Whipple's procedure, which, as you know, is a very complicated procedure for pancreatic cancer, and was in the surgical ICU recovering. And as I was looking at him, he had a fever. So I was called to see him for quote unquote medical management, which is when our surgical colleagues say, we don't know what's going on, come help us. So I'm looking at this guy's case and I see he's on IV insulin, he's on broad spectrum IV antibiotics, and he's on TPN. So I'm figuring out what to do with this guy and what to recommend. And I got a tap on the shoulder. It's a surgical critical care fellow. And he's like, hey, could you also help us with this question? What central venous catheter is best for this patient, given that he's going to need access for a while? So it's got me thinking, if I were to make a wish list of the ideal central venous catheter, what would that wish list look like? Here's Vineet Chopra's wish list for the ideal properties of central venous catheters. First and foremost, for all the residents in the room, they got to be easy to put in, right? You know, this is often the biggest barrier. I see all the chiefs nodding. Oh yeah, to put these lines in. So the ideal catheter should be easy to put in. Second, ideally, they should be free of complications. And when I think of complications, I think of the big three: mechanical complications, infectious complications, and thrombotic complications. So no catheter is perfectly safe, but the ideal one has the lowest risk of all three. Next, patients are increasingly leaving the hospital with these devices. So to me, the ideal catheter is one that allows it to be self-care compatible, so you can transition across journeys, whether you're going from the hospital to the home or hospital to skilled nursing facility. We live in a cost-conscious era. Can't break the bank putting these catheters in, so the ideal catheter's got to be cost-effective. And last but not least, it has to last, right? It's got to last for how long you need it for. Sound like a reasonable list? When you go looking for a catheter that meets all of these criteria, you get a very funny message. We can do transplants in people, but we don't have a catheter today that meets all of these criteria. That's where this man comes in, Dr. Vern Hochal. Quick show of hands. Who of you have heard of Dr. Hochal? No one. Okay, good. I had not either when I started this work. So Vern is a U of M trained surgeon. Coincidence, I did not know that. Class of 1964. And he was very interested in developing what he called an outpatient catheter for TPN. So his patients were staying in the hospital many weeks after these very complex GI procedures, and he wanted to get them home. He said, how do I get them home? Because they need this line and they can't get home without nursing care. How do I develop an outpatient catheter? And he said this catheter had to have three requirements. It had to be easy to put in. His patients were coming out of the OR. He didn't want to put them back into the OR. Patients had to care for them, and it had to be durable, right? It had to last. Sound familiar? In May of 1975, Hochal published this paper called Total Intravenous Nutrition with Peripherally Inserted Silicone Elastomer Central Venous Catheters. That's a mouthful. Let me tell you what he did. Hochal created this device, something he called a crank introducer unit. So for those of you who are entrepreneurial, I don't recommend calling things crank introducer units, just not sexy. But Hochal did, and what it was a hollow needle over a drum kit on which was a spooled wire. And Hochal would palpate the veins of the upper extremity, put this needle into the vessel, and put two fingers into these two holes, crank the drum to advance a wire down into the central circulation, over which he would then slide a catheter. Crank introducer unit, peripherally inserted catheter. What was totally cool about this was a whole different era of IRBs. He not only developed this device, he actually put them into patients. So he inserted 36 catheters using this methodology. The mean dwell time was 20 days or so. 30 of the 36 lasted the entire duration. And you may say 20 days, what is that? Remember in 1975, you were lucky if your triple lumen CVCs lasted a week. And then you had your Broviacs and your more advanced catheters that would last months, but those were more invasive. So this was really middle of the ground in those days. But 6 catheters, so 20% developed infection and phlebitis. And what Hochal did not know then, and I talked to him when I was starting this journey of mine, I said, what did you know about the catheter? He did not know that this would become the modern version of the peripherally inserted central catheter, also known as the PICC. We've come a long way since the days of Hochal. PICCs come in all shapes and sizes now. We have on the bottom right, vascular access teams, usually nursing, that are essentially inserting these devices at the bedside. But the question I have is when you think of my list of ideal properties of central venous catheters, how do PICCs stack up with these three dimensions? So today, I'm going to talk about the first few, the insertion issues and the complications issues. And I'm going to, in typical evidence-based style, create for you an evidence scorecard, where we're going to compare PICCs to non-PICC central venous catheters, looking at those major criteria in terms of ease of insertion, mechanical complications, thrombosis, and infection. Now, for my talk today, I'm not talking about dialysis catheters when I talk about non-PICC central lines. Those are very different. We're not going to go there. We're going to compare PICCs to ports and central lines and other venous catheters. Sound good? Okay. Let's talk about ease of insertion as our first one. Quick show of hands. Are PICCs easier to put in than central lines? Raise your hand if yes. Pepe raises his hand right off the bat. I love it. They are, right? That's their key advantage, right? Is they're easy to put in. So in adults, we put them in the veins of the upper extremity, typically above the elbow. Why? Because if it's below the elbow, what happens? You kink the catheter when you flex your arm, so now it's above the elbow. And as a consequence of putting them there, not only are they easy to put in, but they're also safe to put in, right? So this is a diagram of the venous return of the upper extremity of the limb. And what you can see here is we typically place PICCs in the brachial or the basilic veins. Those are the two largest veins of the arm. We use those veins, and by doing so, we avoid the big three complications: trauma to the vessels of the neck and the chest, right? Those of you who ever hit a carotid or know a subclavian, you know what I'm talking about. Number two, pneumothorax, which I learned when I was placing lines. If you haven't had a pneumo, you haven't placed enough lines. Give it time, it'll happen. And then last but not least, bleeding, right? Because when you bleed with a PICC, what happens? You put pressure on the site and you have the humeral head right there to compress. You ever try compressing a carotid or an IJ? It's very hard to stop bleeding at those sites. So PICCs are safer to insert. Now, everyone says it's the arm. The arm is what makes it safe. It's not just the arm. It's also about the use of ultrasound. Just like with central lines, ultrasound guidance increases the safety of insertion of PICCs. It's associated with fewer earlier and later complications than the way Hochal did it, the blind way. It increases your time to venous access. You actually get there faster because you're spending less time at the bedside. You're reducing overall costs of the team. And it allows you to do something critically important: mapping of the arm veins. What do I mean by mapping of the arm veins? I mean, you can look at the venous capacity of the arm. Does this person have one teeny tiny vein left? And if so, is that the best catheter choice for that person? And the most important thing is you get to see the size of the vein and the size of the catheter, which we'll talk about in a second, is a key safety issue when it comes to the use of these devices. And last but not least, you get to look at where you should puncture. Veins have valves. Veins are tortuous. If you don't know where you're going, you're going to miss it. And ultrasound lets you see below the skin to be able to guide your needle to the vessel. So ultrasound is key to safety. Let me show you some data that makes this point. This is an RCT from China, 240 patients, all of whom were getting chemotherapy. They were randomized to receive a PICC with ultrasound guidance or the PICC the old-fashioned way, the blind anatomic way. And what you see here is a bar graph showing complications of the two groups. The red is the blind, the blue is the ultrasound. More red than blue, right? So more complications in the blind group. Important graph in the middle. Look at the DVT and phlebitis rates. None in the ultrasound guidance group. Why do you think that is? What drives that? It's the number of insertion attempts, right? So the more you stick a vein, the more likely you are to get inflammation, phlebitis, and thrombosis. The ultrasound guidance group had half as many attempts on the vessel than with the blind group. So it's all about using ultrasound to be able to see where the catheter goes in. Let's talk about another safety mechanism, which is EKG guidance. How many of you know we use EKGs to place PICCs? A few of you do. Good. Okay. So what is this? It's actually really cool. So when you place a PICC, you put a wire inside the catheter, and you actually track that wire as the catheter advances using a surface EKG. So you get an internal probe to track the presence of your catheter tip. How does that work? This is a BARD device. I have no relationship to BARD, but they have a sensor that sits on the patient's chest. Looks like a triangle. And that sensor tracks the presence of this wire as it's advanced forward into the catheter. You see it goes from yellow to green. Green means you're at the right spot. What's the right spot? Right spot is the junction of the SVC and the right atrium, the cavo-atrial junction. That's the right spot because that's where blood flow is the greatest and the risk of thrombosis is the lowest. What else is in the cavo-atrial junction in relation to EKGs? The sinoatrial node. So what this device does is it basically gets a surface EKG. You'll see that on the very top, the white line, and it gets an internal EKG on the bottom. And the moment you get close to your CAJ or your sinoatrial node, your P wave becomes biphasic, which you can see on the bottom line. And you know now you're at the cavo-atrial junction. Why is this so good? Because X-rays are single units of points in time. I can take a deep breath and my catheter can move 5 centimeters. And when you take that one X-ray, you're seeing it static, when in fact it's a dynamic object. This is physiologic, it's dynamic, and it actually allows you to guide the catheter better. Does it improve safety? So we studied this. This is with work from our colleagues in Australia. We looked at DVT with PICCs, and we looked at whether EKG guidance was actually associated with a lower risk of thrombosis compared to non-EKG guidance. And what we found here, as you can see, is the use of the ECG actually led to a significant reduction in the risk of thrombosis after adjusting for a number of other factors, 26% reduction. And this makes sense if you think about it, right? You're actually guiding it to where it needs to be as opposed to where you see it on a picture. At UC Health today, in all of our hospitals, every PICC is placed with EKG guidance. This is happening right now. The only exception are patients who don't have a native rhythm, i.e. they have AFib, or they have other rhythms where there's no P wave. And in those cases, we still do chest x-rays. But it's suboptimal in many ways, all right? So I hope I've shown you evidence that says when it comes to ease and safety of insertion, the PICC wins over other central venous catheters. Let's talk next about mechanical complications. And when I talk about this, all the students and residents say, well, why do I care about that? That's a nursing problem. I don't really treat catheter occlusion. Let me show you some pictures. So this is another patient. This is in our surgical ICU again. He had a thoracotomy for lung cancer. You can see the staples there. If you look closely, the patient is still intubated. There's still an ET tube down the throat, and there's also an NG tube going down, and I can show them to you over here. And if you look here, there's a catheter that's coming in from the arm, but instead of going across, it actually curves back towards the chest wall. So what's happening? A vascular access nurse was asked to place a catheter. She tried to place the catheter. She got resistance. She paused, got an X-ray, saw this was not going the right way, stopped the procedure, went to the opposite side, placed the catheter in the arm, no harm, no foul. Left side was fine. Here's one that did not go as well. This is a 37-year-old male who basically left the hospital a week ago on IV vancomycin for a skin and soft tissue infection. He comes back complaining of right-sided numbness and tingling and a funny noise in his ear when he flushes his catheter. We have an abstract on it. It was called Whoosh, There It Is, for those of you who are from the 80s. And what happened was this person was doing push-ups at home because someone said, you need to stay active. But no one told him, don't do push-ups with your catheter in your arm. So this catheter that was essentially placed at the right position when he left the hospital was now up in the right IJ, where he was feeding himself concentrated vancomycin twice a day. True story, he comes in, he says, I have this numbness and tingling. We get a head CT. The head CT says no acute stroke. Radio-opaque object in the right internal jugular vein. Kindly correlate clinically. All of us like, what the hell's in the right internal jugular vein? We got this chest X-ray. Lo and behold, it was the PICC that was up in the right IJ. What's the point of these X-rays? The point is that these catheters move, right? And when you think about mechanical complications, think about early ones that are insertion related, and we often detect those when we're inserting. And the late ones are the ones that we miss a lot. And the late ones are really common. So if you look at the literature, the evidence suggests the incidence is anywhere from 5% to 25%. And it includes a whole host of complications: coiling of the catheter, kinking of the catheter, malposition, phlebitis, and what we call tip migration. The two most important things I want you to know are malposition and tip migration. And when I say that, what I mean is the catheter tip is no longer at the SVC and right atrium junction. And as you now know, that's a problem because that's where blood flow is greatest. Wherever blood flow is not greatest, what happens? Blood has stasis. And when there's stasis, what happens? You get clots. So any other malposition sites, often in the jugular, as I showed you in that X-ray for that young man, or the axillary, increases your risk of DVT. You have to manipulate the catheter to get it back. And there's tons of data that says the more you mess with the catheter, the higher the potential risk of infection. So these are not benign complications that we don't think about. How common is this? This is a systematic review and meta-analysis that came out of Sweden from Pickwer and colleagues. And what they compared these 5 studies head to head with PICCs versus CVCs. And they found essentially that PICCs were 3.7 times more likely to move around than other central venous catheters. This included ports as well as IJs and CVCs. It makes sense, right? Every time I move my arm, if I had a PICC right now, you would see the catheter move. It moves with motions, it moves with respirations. These things are long, thin, cylindrical catheters that tend to be very mobile. Is there something we should not be doing or something we should be thinking about when it comes to mobility? Let's talk about CT injections and catheters, because this is a provocative factor for catheter mobility. This is recently discovered. This is a CT scan starting again when we're using the CT for a contrast dye injection through the PICC. This is the beginning of the injection. If you look closely, you'll see the PICC is in the right spot. You'll see some dye coming out of the catheter. And this is the end of the injection. All the great vessels are nicely opacified. Where's your catheter now? It's up tented into the right IJ. Why is that a problem? DVT, right? Because it's not in the right place anymore. Why did it do that? Because you're injecting so much dye so quickly against the tricuspid valve. It's like a garden hose. It pushes back and you hope it falls back into place, but often it does not. Let me tell you about a personal story closer to home at a patient at Michigan. This is a patient who went down from the ICU for a CT scan. You can see the beginning of the injection, that white arrow, the catheter is in the right place. Look at the middle panel on the bottom. Where's that catheter? As soon as the dye starts to come out of it, it starts to loop. A lot of us have redundant SVCs, and so the catheter moves up into the path of least resistance. And then look at the catheter at the very end. Where is it now? It's coiled back into the vessel. Look closely at that last X-ray. What else is on that last X-ray that wasn't in the middle one? Shout it out if you see it. Defibrillator pads. This patient coded 2 days later with a massive pulmonary embolism. Didn't make it. We went back and looked what could have happened. Why did the PE happen? And We had these images at the time. We just didn't know what to do with them at the time. What I like about this paper is they actually conducted an experiment. They raised 2 beakers, they put them under constant pressure volume, and they said, let's inject different levels of fluid and volume to see how much catheters move. On the far left, you'll see your experiment starts at 175 PSI, that's constant state in the experiment, and they inject 4 mils per second in a saline flush. We'll talk about why 4 mils is important in just 1 second. In the right panel, same experiment, half the volume, 2 mils per second of saline flush. Which catheter do you think moved more? One on the left, one on the right. Shout it out. Left. How much more? 5 times more. Why is this important? What goes through your catheter at 4 mils per second? CTPEs, CTAs, CTVs. So the teaching point here is if you're going to use your PICC for any of those studies, you need to check your catheter position before the patient leaves the table. I'm guaranteeing you, they have moved. People have issues with this when they don't get picked up in time. How do you pick them up? You finish your CT scan, you do a scout film, you see where your patient's on the table, where's your catheter tip? If it's in the right place, you're done. If it's not, what do? It's very simple. Take 2 mil flush and flush the catheter and push it off the wall. And usually it drops right back down. It's that simple to do, but it requires a massive flush to move it in the right place, which doesn't happen outside of that setting. At the University of Michigan, when I left, when we did the RCA on this, we essentially now have a protocol where no patient leaves the table until they actually do the scout and check. Okay, why? Because people get hurt if you don't do this. So when it comes to mechanical complications, the evidence is fairly strong. The PICC is not your friend. These things move, they're mobile, and they cause a lot of mechanical complications, as I'm sure many of you know. Let's talk next about thrombosis. And thrombosis is one of my favorite topics. How many of you have had a patient with a PICC-related DVT that you've cared for? Lots of hands up in the room. This is a costly, common-ish, and a potentially lethal problem. The challenge is when you look at the evidence, the incidence is highly variable, right? It depends on which patients you're studying. We know critically ill patients and cancer patients have the highest rate of thrombosis with these catheters, but it also depends on how the study looked for clots. So newsflash, if I scan you every day after you have a PICC in a week, what proportion of people actually have a DVT that you can scan? You'll be shocked. 1 in every 3, 33%. How many of them are symptomatic? 0. They don't know they have it. And this is a big controversy in the literature. What do we do with those clots? My inclination is when I notice a clot there, I treat the clot, but treatment is not benign, right? The symptomatic studies, the incidence rates are much lower, 3 to 4%. And we don't know what to do, whether you're symptomatic or asymptomatic. It also depends on the studies and how they look. If you use ultrasound, ultrasound is great for clots that are in the arm. It is not good for sensitivity and specificity when you go deeper into the chest. You just don't get great windows. So CTAs, MRVs, those types of studies are much better for detecting deeper clots. So this is very, very mixed in terms of the literature. Here's the point I want to make to you, that the presence of a PICC in a hospitalized patient has been shown to be one of the 4 strongest predictors of thrombosis in the hospital. Think about that for a second. What are the big risk factors for DVT? It's cancer, right? Immobility, having had a prior DVT, critical illness. And I'm telling you, when you choose to use this catheter, your risk of causing that event is just as much as those other underlying conditions. These are very thrombogenic devices. How thrombogenic? So we studied this in a meta-analysis we published in The Lancet. We started basically by stratifying 62 studies based on where patients were when they were diagnosed with their DVT. So if a patient was in the hospital in the regular wards, the incidence of DVT was about 3.4% in those studies. If they were a cancer patient getting cancer care or chemotherapy or on a cancer unit, the incidence doubles to 6%. And heaven forbid they're in the intensive care unit, critically ill, and use a PICC, because those studies had the highest risk of thrombosis in these patients. Put it all together, that's about an average of 4.8% in terms of risk. Many of you are going to say, Dr. Chopra, 4.8%. There's other things that are damaging. What's the average risk of DVT in a general medical patient? Do we know what that number is? It's less than 1%. In fact, most of the work now is on de-emphasizing VTE prophylaxis for everyone, right? Because we know it's not as high risk as we thought. And so again, your choice to use this device fundamentally changes the equation with respect to thrombosis in these patients. How big is this risk compared to other central venous catheters? It's quite large. 12 studies head-to-head in this pooled meta-analyses, 2.5 times greater risk of DVT. We have since updated this study. We now have a total of almost 50 studies comparing PICCs to CVCs. It's still 2-fold higher. than other catheters. And this makes sense if you think about it, right? These are, again, slender catheters in smaller vessels. They move, they cause problems, and so they cause DVT. What if you really need a PICC? It's the most appropriate choice for this patient. What could you do to prevent it? How many of you have heard about this catheter to vein ratio concept, or CVR? Dr. Connors is nodding his head. Anybody else heard about this? This is another contrast. See a hand in the back. Hello, Amiran. Nice to see you. The difference is, if I talk to nurses about this, everyone nods their head. And this is the classic example of how we don't know this literature as well as they do. What is a CVR? It's actually very simple. If you use ultrasound for your catheter insertion, which you should, you can measure the cross-sectional diameter of a vein, right? So this is a basilic vein that's 53 millimeters in length. What if I put a 50 millimeter catheter in that vessel? Where will blood flow in that vessel? In that 3 millimeters between the vessel wall and the actual lumen, right? Because you're blocking the lumen, right? So remember good old Virchow? Virchow's triad, right? So you put a needle into a vein, you cause endothelial injury, right? You're doing it in a patient in the hospital, is often hypercoagulable. And then you put in a large hose into the vessel and stop blood flow to cause venous stasis. What do you think is going to happen? They're going to have a DVT. So what's the CVR? What's the catheter vein ratio rule? Very simple. Never ever exceed 50% of the cross-sectional diameter of the vessel. What makes you go more? When you ask for more lumens. So when you tell your vascular access team, hey, I want 2 just in case 1 goes down, you're changing the equation when it comes to safety for that patient. The beauty of the CVR is it's very operational, right? So you can actually measure the vein. You know what your catheter size is, it's right there on the box, and you can do the math in your head. In the 53 millimeter vessel, those are the 3 catheters you could choose in terms of thinking about the right size. Simple math, right? Never exceed more than half the diameter of the vessel. Now, does it work? This is a very small study from Australia that we're currently still continuing. We looked essentially at 136 patients. We found that 45% was the better cutoff, not 50%. So don't go more than half the cross-sectional diameter of the vessel. And if you do that, there's your model, 75% sensitive, 83% specific. That's not bad. Again, the beauty of this is you can map your catheter size to your vessel size. I'm a really simple guy, so it's always an N-1 rule for me. If you have a 4 French catheter, you need a 3 millimeter vessel. If you have a 5 French catheter, you need a 4 millimeter vessel, right? It's easy, and you can do the reverse. And what happens if you violate this rule? What if I say to my vascular access team, I need you to put that triple lumen in because I just like 3. I want 3 lumens in this patient just in case. Okay, the moment you violate this rule, your risk of thrombosis goes up almost 13-fold. That's a very large confidence interval. It's because the number of events is quite low in this study. We now have almost 600 patients in that study. It is 10-fold higher still on the analyses. So the CVR is a key way of preserving the safety of these devices and ensuring your patients have better outcomes. But thrombosis, this is not your friend, right? Especially in the patients that we take care of in the hospital, the hypercoagulant patients, the oncological patients. This is where we get into trouble with these devices. And this is why it's not the best choice. See a lot of ID faculty in the room. Let's talk about infection and what this looks like for PICCs. This is seminal reading for all of you. This is Dennis Mackey's landmark paper, one of the first papers I read about the risk of infection with various intravenous catheters. And Mackey and colleagues looked at 200 published prospective studies, therefore higher quality, and essentially found when you pooled the data together, the lowest rate of infection was peripheral IV catheters, 0.5 infections per 1,000 catheter days. PICCs somewhere in the middle, 0.5 to 2.3 infections per 1,000 catheters. And what had the most infection? Those darn CVCs that we put in the neck and in the chest, the highest risk of infection compared to other devices. Okay, so quick show of hands. How many of you think that PICCs are therefore safer when it comes to infection based upon these numbers? Raise your hand. Thank you. We all thought this, by the way. This was a rhetorical question. And this is one of the reasons why when you talk to Mackey today, he'll tell you this is his biggest regret about this paper, is that people looked at this and said, oh, they're safer. We should use more of them. They're better. And we did. And there were lots of very elegant theories about how PICCs may reduce the risk of central line associated bloodstream infection. Let me jog your memory a little bit. First and foremost, the flora of the arm and the temperature in the arm, very different. Therefore, you have less bacteria. Less bacteria means less infections. Less infections is good for the patient. Therefore, PICCs are safer. Theory number 1. Theory number 2, that somehow the longer length of the catheter is protective. The bacteria have more to walk down before they can actually cause this biofilm to form. We all laugh. These are out there. These are all published out there. So this is protective. And last but not least, if you look at our nursing colleagues, they'll ask you, it's just easier to provide care at the arm, right? It's about site care at the end of the day, right? Try keeping a catheter in the neck hanging off, clean and dry and intact at the entry site. It's very difficult to do. These were all great theories, right? And there's probably a little bit of truth to all of them, but they were all wrong. Why were they wrong? Remember who was getting PICCs in 2006? It was patients who were ready to go home. It was largely outpatients. And it was patients essentially who were looking backwards, so limited data sets, right? So it's the Hoshal family, those patients who were ready to go home. And I said, well, it's a fundamental difference between how I'm using a PICC in the hospital and how these are looked at outside the hospital. But people said, oh no, there's no data for that. So being the researcher that I was at the time, I said, well, let's create the data. So we did another meta-analysis where we stratified studies based upon where patients were. If patients were in and out of the hospital with their PICC, no difference in the risk of infection. The blue diamond crosses that vertical line, no difference in bloodstream infection between inpatients and outpatients. There was only one study that only looked at outpatients where the risk was significantly lower. This is Nancy Moreau's study looking at a broad range of patients who never touched the hospital. And if any of you have ever had a PICC or actually cared for a patient who had a PICC, I will tell you this. When you have your PICC or your family member has a PICC, they take better care of it than we do. It's their lifeline. And there's a reason why infection risks are lower. Talk to any dialysis patient. They'll tell you when they got their infection. They know who did not wash their hands or who was not taking care of themselves. And this is the power we have as healthcare providers, right? It's our responsibility to do this, but we often fail in this respect. This is the hospital. This is where I was working. This is where I was seeing all these PICCs going. These are all the studies looking at hospitalized patients. We did the meta-analysis and found no difference in the risk of infection between PICCs and other central venous catheters, right? And overall, that bottom orange diamond, no difference. And this makes sense, right? There's nothing special about inserting a catheter in the arm or the neck or the groin. They all provide access to the bloodstream and they all can cause infections. So we published this in 2013. A year later, Shea and IDSA came up with updated guidelines for prevention of CLABSI. And here's what they said. They said, do not use PICCs as a strategy to reduce the risk of CLABSI. That is what we were doing. We were using PICCs over other lines to reduce bloodstream infection. And the risk of infection with PICCs in the ICU approaches that of CVCs placed in those IJ and subclavian locations. And most CLABSIs due to PICCs are not happening in the ICU. In fact, 2/3 of central lines are outside the ICU today. And the risk of there is very different. I had nothing to do with these guideline changes. I will tell you one really important thing, and this is why I would recommend considering a health services research career. All of those studies cited come from our group. And this was great to see because we were seeing evidence change practice in a very meaningful way. What if you actually do need to use a PICC? It's very simple, right? Same thing with DVT, minimize the number of lumens. This is 1,200 patients from the Ann Arbor VA, all of whom were discharged with a PICC. We looked at basically time and risk of CLABSI. The bottom line, the blue is single lumen catheters, the red is double, the upper line is triple. You can see the most events happen in the triple lumen catheter group, double somewhere in the middle, single is the lowest number of events. What's not shown here, but what's important is those graphs change statistically at 7 days. So your decision to place a second lumen affects that patient not 30 days later, as we often think, but as early as a week after you place that central line. Now, some of you in the room are gonna say, Dr. Chopra, but those triple lumen patients, those are very different. They're in the ICU, they're sick. It's not the catheter that's driving the risk, it's the patient. So we looked at that. We adjusted multiple different ways using our models. And what we found essentially is the strongest predictors here in the bottom, the number of lumens. So compared to a single lumen PICC, a double lumen PICC is associated with 4 times higher risk of CLABSI. Compared to a single lumen PICC, a triple lumen is 6 times the higher risk of CLABSI. Those numbers were shocking to us. And I think this is the reason why we harp about using less lumens when it comes to these devices. There are significant outcomes to patients. But I'm gonna be fair, when it comes to infection, the PICC is gonna be flat, right? There's really no good data, there's just one is better than the other. It's basically a wash. So that's the scorecard. What's the verdict? Are PICCs the central line of the future? Who thinks yes? Have I convinced all of you? Who says, I'm not sure, maybe? Hands up. And who says no? Okay, my answer is a little different. It depends. Always a good answer when you're a researcher. It depends. What does it depend on? Let me explain this to you. It depends on the patient, right? You now know that there are some populations at higher risk of thrombosis and infection than others. It depends on the device. You now know that multi-lumen catheters and PICCs that are of greater gauge actually have a higher risk of complications than others. And it depends upon you, right? Are you using ultrasound and EKG to reduce that risk? Are you choosing the right device? Are you respecting that catheter to vein ratio? But I'm going to leave you with some closing thoughts. And I'll tell you that I think if you think about the current use of PICCs in one word, I would call this suboptimal. True story, I gave medical grand rounds at Wisconsin. Someone in the audience liked the slide so much, they actually mailed me a t-shirt with the word suboptimal on it. I couldn't tell if it was because of the slide or because of me, but regardless, this is true. And let me show you some data that makes this point. So for the past 15 years, I've been leading this wonderful clinical laboratory at Michigan. This is 62 hospitals now, all of whom are working together to actually improve patient safety. It's hilarious. You go to these hospitals, on the way on the highway, there's a sign for the competitor that says, come to us, we're better, we have better programs. On the back end, there's a sign that says, no, you come to us, we have better programs. And yet when we're in the room together, all that goes away. We're talking about safety, we're talking about the patient. And there's a project that I lead focusing on catheter use and outcomes where we study various things. And this is data from that project. This is the first paper we published. So let me walk you through this slide. This is the documented indication for why a PICC was placed within a hospital. Each of these vertical bars here is a hospital. The height of the bar reflects the percentage of central lines that were PICCs relative to other CVCs, subclavians, IJs, and ports. So in hospital 846, 90% of those central lines are PICCs, whereas in hospital 884, let's say half were PICCs, okay? The colors in the graph represent the documented reason why the PICC went in. We don't get this from claims data, we look at the notes. We'll look at the provider notes, we'll look at the insertion provider notes, we'll look at the radiology notes. So blue is home antibiotics, red is difficult access, orange is unknown. We looked, and we couldn't find a reason why someone had a PICC. And this is now 4,000 PICCs in 10 hospitals, okay? 2 points about this graph. One, just look at how much the use of PICCs varies just in these 10 hospitals, right? If you go to hospital 846 and you need a central line, I'm gonna bet good money you're getting a PICC. Whereas if you go to the hospital at the far right, probably 50-50. And second, can you find me 2 hospitals that look the same with respect to why they're using these devices? We're now almost 60,000 patients into this data. It's still hard to find 2 hospitals that look the same. This is the power of culture and how we practice within hospitals in terms of thinking about variation in care, right? Now, we'll submit to you, now that you know these complications, that's a shame, right? These are patients that are potentially going to be more at harm based upon the culture of a hospital and how things are performed at that site. All right, so that's indications. Let's talk about dwell time and how long they stay in. Again, 4,000 catheters, almost 1,000 came out within 5 days of going in. In fact, over 50% were removed within 2 weeks. And why is that 2-week period important? I'll tell you in a second, because there are probably other safer alternatives to consider in that 2-week period, right? Let's talk about lumens. You know the importance of lumens. Let's talk about the variation in lumens. So this is, again, the same stacked bar graph. Let me orient you a little bit. Again, each of the vertical bars here is a hospital. The colors now represent the number of PICCs that were either single lumen in blue, double lumen in red, or triple lumen in green, okay? So on the far left, hospital 834, let's call this my single lumen hospital. For whatever reason, the majority of PICCs placed there are single lumen catheters. This hospital on the far right, let's call this my double lumen hospital. For whatever reason, the majority of catheters you get there are double lumen. And where's the one in the middle? There you are, 884. That's my triple lumen hospital, my special hospital. Whatever you do there, for some reason, you get triple lumen catheters. Shout this out. Do you know why these vary so much? What do you think the reason is? Culture? Culture, perhaps. It's even more simpler. It's the default option in the electronic order set. Can you imagine how simple of a change to make such a profound impact to patients? Hospital 898 had a double lumen default. Hospital 884 always defaulted a triple lumen. All right, which hospital has the most DVTs? Shout it out. 884, this is a fact. Which hospital has the lowest risk of CLABSI? Hospital 834, right? Most single lumens, this is a fact. These choices matter, right? The data actually shows that. So I talk about this, people say, okay, Dr. Chopra, that's great, but you can't do this. We need a method. How do we do this, right? And so that method is something that we published back in 2015, something we called the Michigan Appropriateness Guide for Intravenous Catheters, also fondly called as MAGIC. I'm happy to talk to you about how we came up with the acronym at the far end. This was before Colorado, there was no marijuana involved, but it was an interesting experiment of coming up with that acronym. But what is MAGIC? MAGIC is a tool that tells you when you should versus should not use a PICC in a hospitalized patient setting. We created this using something called the RAND UCLA method. It's a very well-defined, very robust methodology. It's used by CMS to determine what they will pay for versus what they won't. I put together 15 of the world's experts, including a patient, to try to come up with what guidance we should consider. I was not interested in a hospitalist-only guideline. I wanted to create something that would help people outside of my field make good decisions. Who are these folks? People you know. First authors of major guidelines, great clinicians, policy experts, and researchers. And I wanted multiple specialties. So we had radiologists, we had cancer docs, we had hospitalists. ID docs, ICU docs, thrombosis experts, not one, but two vascular access nurses because they often have differing viewpoints, and then a pharmacist and a surgeon. And I had the joy of writing 677 scenarios for us to rate as to when it would be appropriate to use a PICC versus not use a PICC. Note for you guys, this is not your first research project, right? Don't start with this. All right, so MAGIC is all about the PICC. The PICC is in the middle, but you can't tell someone you can't use a PICC. You got to tell them what should they use, right? So MAGIC compares PICCs to peripheral choices. On the left side, peripheral IVs, ultrasound guided IVs, and midline catheters. And to the right, central options, including non-tunneled, tunneled, and implanted ports. It's the only guideline that I know of that actually compares all these devices when you're thinking about use across specific patient indications. How does it work? These are ratings. So this is the way we created it. We essentially have all the devices on the far left. You'll see them listed here from peripheral IV all the way down to port. And then we have duration of therapy on the right axis. And then the colors represent how the committee voted on various scenarios. So green is appropriate. So take a typical hospitalized patient in the hospital 5 days or less. You've got 4 choices there for using a peripherally compatible therapy in a vascular access device. Notice where the PICC is. The PICC is red. We do not recommend using a PICC for less than 5 days. How many PICCs were in for less than 5 days in Michigan? Almost 25%, right? So this is a huge area of opportunity for peripherally compatible therapies. It was not designed to be algorithmic. It turned out to become algorithmic because it's such a linchpin in terms of duration of therapy, right? This is the same thing when you think about other devices in terms of ports and tunnel catheters. You don't want to use more invasive devices unless you need longer care. But you want to think about them when you have that sickle cell patient in front of you who's there with their 9th admission this year and they have no veins left. What are we doing, right? We need something more reliable in this patient, or the hemophiliac, or the patient who's on TPN. You can't keep putting PICCs in these every single time. Sooner or later, you're going to have a thrombosis or a complication. So do the right thing. Give them a device for life, right? So we published this and then we said we'll study it. So we actually used one of the hospitals in those graphs I showed you. I will not tell you which one, but they had a lot of complications. I'll leave it at that. And so they decided to implement MAGIC to say, hey, could we reduce complications by using less PICCs? So this is what they did. This is their typical use pre-intervention. They were using 8 to 12 PICCs per 1,000 patient days. That's a lot. This hospital was 150 beds. It's a lot of PICCs. Here's what happened after they implemented. They see a sustained and immediate reduction in PICCs. This has been shown time and time again when you implement MAGIC, right? You see a 30% reduction across institutions when you actually use this guideline. What happened with these devices? They were shifting to less invasive, more peripheral choices. And so what happened here was the midlines before intervention were hardly being used, and after intervention, midlines went up. So they shifted where those devices were going. This is what happened with their PICC choices. It wasn't just about choosing the right choice. This hospital was using a lot of triple lumen catheters and double lumen catheters, shown here in the yellow bars and the blue bars. So about 100 to 120 catheters a month. And again, not much green, so not a lot of single lumen use. Here's what happened after they intervened. Again, you see that 30% reduction in the overall use of catheters, and look at the green bars, right? This hospital went from being the worst of our 60 hospitals to being the best. And how do they do it? They empowered the vascular access team to be able to choose the right device, and they changed the default on their order set. Literally that simple. We've done this now across the state of Michigan, across 60 hospitals. This is data over quarter looking at appropriateness. This is 25 quarters. This is almost multiple years of work. You can see since we started, appropriateness has been going up. In that same period, complications from PICCs have been coming down. And when you overlay the graphs together over time, you see that every time you increase appropriateness, you see a decrease in complications when it comes to the use of PICCs. We published this data most recently in BMJ Quality and Safety, looking at whether a PICC was placed for appropriate indications per MAGIC or inappropriate indications. And what we see is that if a PICC was placed for appropriate reasons, it actually had significant reduction in the risk of catheter occlusion, almost 75%, because you're using lesser lumens. Significant reduction in CLABSI, almost 39% reduction in CLABSI, and VTE dropped by almost 60%. Overall, you drop your complications by close to 81% with the use of this tool. There's not a lot of things in the vascular access world that can reduce your risk of complications this way. So this is pretty powerful. And again, very large scale data in almost 40,000 patients worth of doing. The SHEA IDSA guidelines essentially have recently been updated. Again, I had nothing to do with this, but I'm proud to see it. They now talk about decision-making before you choose a catheter, as opposed to just inserting the catheter as the beginning point. And they say, before inserting, use an easy to access evidence-based list of indications for CVC use to minimize placement, and the reference they cite there is MAGIC, which is great. There are other references as well, which is also great because there's multiple ways to get to this, but the point is think before you place your catheter in terms of what may happen to that patient. We are doing this work here. I am part of our CLABSI KEG, or our clinical effectiveness group, where we're rethinking how we think about CLABSI in the institution across all of our sites. We are working on creating a universal insertion note. So there's one note for how you insert catheters, and then guidance as you choose your catheter types. For example, when you hover over a catheter, it tells you what that catheter is and when you should use it. Ultimately, we're going to start actually directing you towards the right number of lumens and the right catheter size as well. So more to come in terms of CLABSI. This is a problem here, by the way. We don't do well with this metric at UC Health. So this is a key strategic initiative for us to improve our national rankings, but more importantly, do right by our patients. So more to come. How do you do this today? Well, there's an app for that. So this is where I want you to take out your phones, all of you. If you have an iPhone, point it to that QR code. If you're at home, you can do the same. If you're on an Android, search for Michigan Magic in the Play Store. That QR code should take you to that as well. I'll put it up there for just a second in terms of the app. What does the app do? It walks you through the algorithm. So it has a very nice fancy splash screen. It asks you which of the following indications are you ordering a PICC for. Let's say I'm choosing IV antibiotics as my indication, the most common indication for PICCs. The next question is, have you obtained ID approval for that therapy? My ID docs love this when I show this to them. Neil Fishman at Penn tells me when you look at PICC orders, about a third of them, you don't even need a catheter. But a third of them could be oral, and only about a third of them do you really need to have a PICC. So again, this is a pause in the process before you place these devices. Let's say they say yes. The next question is this peripherally compatible? What you're trying to infuse? I don't know what's perfectly compatible. So there's a list right there for you. Click on it. It'll tell you which antibiotics are compatible versus not. The next question is, what's your duration of therapy? Again, that's the key fulcrum for MAGIC in terms of deciding between which devices. And then you get your appropriateness. Green is appropriateness, red is inappropriate, and you have some additional information. Ascension hospitals in Michigan, almost 66 hospitals across the state, use this as their insertion checklist when they choose their catheters. It's actually in the EMR, a picture of the actual MAGIC output. It's pretty cool when they actually use devices. So this is for you. Use it at the bedside. When you're rounding, hey, we should get a PICC in this patient. Well, should we? Let's take a look. Let's do it together, right? This is where it's really helpful as a teaching tool before you're making these choices. I'm gonna go back to our case I started with, the young man in the ICU that I saw, right? That remember, the 68-year-old guy who had all these complications with pancreatic cancer. I was asked which central venous access is best. So here was my thinking at the time, pre-MAGIC. He's critically ill in the ICU. Don't want to put a PICC in him. He'll have a thrombosis, he'll have a complication. My next question was to the doc, how long do you think you'll need access for? This guy's going to be on TPN for a while. It's okay, probably a couple of months. So he was already on the right side of my decision making. We put a tunneled catheter in this patient. This patient did well. 68 days later, the catheter came out. This is the patient that came back for the MAGIC panel and was actually our panelist when we made the decisions. So a nice way to end the story as well. You'll find more information on improvepic.com. This is where we keep all of our evidence base available to everyone. And again, very grateful for the invitation. I'm glad I could do it today. Happy to answer any questions. Thanks very much.
Throw things open to our audience. Dr. Johnson.
The infection rate, first of all, it was great. The infection rate with single lumens is pretty compelling. If you did your comparison of PICC versus central and just combined it to single lumen catheters, would PICCs have the advantage?
Good question. We haven't done that comparison. The largest reason why is because it's hard to find single lumen central venous catheters. They're hard to actually secure. My suspicion is it'll probably be the same. I think the challenge is just stocking them on the shelf so that people actually have them. When we talk to ICU docs about using less lumens, the biggest pushback I get is we don't have doubles. We don't have singles. So this is part of the strategy of making the right equipment available to you. My sense of it is there's no difference in the risk between a single lumen central line and a single lumen PICC. The challenge is going to be how do you actually get those available to the patients so that you actually get them in at the right time. That's a great point, Steve. Thank you.
Thanks for a great talk on something that just is deceptively simple, but so common. It would seem that you probably are pushing people to midlines in a lot of cases. What do we know about the risk of infection in midlines versus PICCs?
Yeah, great question. I wouldn't say pushing people to midlines. I think we're pushing people to less invasive strategies when they're appropriate for the patient. So an ultrasound guided peripheral, even a peripheral IV catheter, which we're now saying keep in as long as you need. Don't routinely change them in terms of the evidence available. There are indications where the duration of use is between that 6th day to that 15th day, that 2-week mark, where midlines tend to outlive peripheral IV catheters and have a place. The evidence that we've seen so far, and some of it that we've created, suggests the following. Number one, that they actually do have a significantly lower risk of infection compared to PICCs. Unclear why. They're still peripheral catheters, so you would expect potentially there is a risk with them. I think it has to do with dwell time. They're in for shorter periods of time, often that 6 to 8 day window, so they don't have the time to actually have a pure-on bloodstream infection. But multiple data sets have shown lower risk of infection. The problem with midlines turns out to be thrombosis. So data that we've published and shown that I didn't show here today shows that they actually have a very high rate of DVT, a little lower than PICCs, but not insignificant. So this is where the conundrum begins. When you're dealing with a patient, for example, who's hypercoagulable, like a cancer patient, but doesn't really need central lines, what is the best choice for that patient? Do you put in multiple peripherals and do that over time? Should you put a midline and take the risk with that patient? What if it's a patient who is not hypercoagulable? Is a midline the right choice for that patient? This is where the evidence is currently still developing. We know that midlines have lower inclusion, lower infection, but we know the thrombosis rate is pretty high as well. And there are multiple new technologies coming out now to try to reduce the risk of thrombosis with midlines, including fancy coatings, smaller length catheters, whatnot. And I think you'll see more evidence in that space in the future. But I think the key point for you and for the learners in the room is think twice before using a central line. If you don't need central venous access, stay away from that right side of that graph. Think about your peripheral options as your first choice. Thanks for that great question. Three ID docs in a row. Wow, this is great.
So one of the issues we run into on the infectious disease service quite frequently is patients that are using intravenous drugs. I didn't notice anything on the app that asks, does your patient choose to inject their drugs and whether that influences the choice of a line?
Good question. So IV drug abusers. The other thing that's not on the app, I'll just say right now, is chronic kidney disease, which is also a relative contraindication. We're working on app version 2.0. By the way, the app was coded by me and a med student. And so I have a little time issue these days, but I'm getting to it. IVDA, huge issue with PICCs. In fact, when you have a patient who essentially is likely to use drugs intravenously, the PICC is probably going to be a problem in that setting. There's a couple of ways to think about this. The first way, the most sort of blunt force instrument, keep them in the hospital. But even when in the hospital, though, we get into trouble. I've seen patients in the hospital use their line for things they shouldn't use. So it's not a panacea, right? Number one. Number two, there are locks that you can buy now. They're called TET locks, T-E-T, that actually sit around the lumen of the catheter. And the locks essentially are magnetic. You need a special device to unlock them, so you can't actually access the lumen unless you have that special device to open it. They're pretty cool because the moment you tamper with it, it turns color. So it pulls and whatnot, so it turns red. So you can tell when a patient essentially has not been good or perhaps accidentally pulled too hard on their catheter. I have seen patients that chew their lines and actually get that lock off as well. So the way I think about it is this, is this a patient that's going to be collaborative, and is this a patient that's going to cooperate? If yes, we give the benefit of the doubt to them. You can think about locks, you can think about additional strategies. More importantly, you have the patient sign a contract that says, hey, we're trusting you. We need you to see your end of the bargain. Locks work a lot, but locks are not foolproof. And if a patient is going to abuse their line, they're going to abuse their line. So the locks, I feel like, have a place maybe as a deterrent in some of those middle cases, but not as a long-term solution at all. It's a very tricky situation. I know our ID colleagues use a lot of IM antibiotics in those patients. We're often making difficult choices about orals in those patients because we don't know if the IV is going to be safe. Sometimes I worry that suboptimal treatment happens in that context, but given all the social factors, certainly an important weighing factor. There's no good answers. At Michigan, we just sent some of them into skilled nursing facilities where we actually had long-term contracts where they would be watched. But if you've ever been to a skilled nursing facility and Hillary just left, they're not watched. You may as well send them home at the end of the day. So it's a tough population in that respect as well. I said CKD, so let me quickly mention this. So PICCs destroy your veins. After the PICC comes out, your vein basically becomes totally obliterated, and you can see that in ultrasound because there's inflammation around the vessel. Some of them recannulate. It depends on how young you are and where your vascular endothelial growth factors might be. A lot of them don't. When you have a patient who's going to end up needing dialysis, those veins are critical to fistula formation. The number one reason why fistulas fail is the use of a PICC in the past. So the teaching is that anyone who has a GFR below 45 mils per minute or CKD3B, do not use a PICC in those patients. And if they're 80 and they're never going to need dialysis, a PICC is reasonable, but you have to have a conversation with them to explain the risks and benefits of those devices. But don't knee-jerk put in a PICC in those patients either. So thought I'll mention that. Yeah, question.
We have one from the chat.
Okay.
The question is, do you have any data on operator experience versus complication rates? And how many PICCs do you need to insert before you are trained? Should you pick your provider?
Ooh, well done. That's great. Okay, so how many do you need? Well, this is about muscle memory. So the more you place, the better you get. I don't know if there's a cut point at a certain level. When you talk to the ICU folks, they'll tell you, you don't get really comfortable till you place your 100th line, but I don't know where that number comes from. Here's a more controversial take on this, which I'm going to put out there, is I am going to say that unless you're a critical care doc, you should get out of the business of placing lines, period. Why do I say that? Number one, we can't place every line. Number two, it takes skill and muscle memory to place these in. Number three, there are people that are much better than us to use them. So our ABIM rules are 5 lines and you're checked off. Let me tell you something, it's not enough. I know, because in my first day in private practice, I had to put in 5 lines. I was like, oh my God, this is my entire residency one night, right? I think that we should get away from this and we should actually let the experts who do it every single day guide not only the choice of the device, but also inserting the device at the end. A lot of docs are going to say, wait, this is our culture and our identity. What if it's an emergency? If it's an emergency, put an intraosseous catheter in. It takes 30 seconds to put those devices in. You don't need a central line. It's easy to do. Anyone can do it. That should be your go-to. Shouldn't be a femoral or an IJ when someone's doing CPR. Those are really hard to do. And last but not least, let the experts come in and make that choice at the very end. This is a very rapidly evolving science. And again, CVR, things that we never are taught in medical school, there are people that know this better than we do. Asterisk, I am currently working with the ABIM to change the certification requirements so that we don't actually have to have a mandate for a number, or for that matter, need to place lines to graduate from residency. So some people are gonna be unhappy, I get it. Place all the lines you want if you so desire, but I feel like most of us in our real world don't need to have that skill set under our belt. We should let other people do it. Time out, and I will tell you, if I'm getting a line, I don't want any of you doing it. FYI. All right.
All right, I'm going to steal the last question since we have 2 minutes left. Seeing that map of Michigan and all the different hospitals made me think of Peter Pronobos's work and other safety culture things that came. How does this overlap with checklists, little antibiotic buttons, and all those other things that we now do that we didn't do 20 or 30 years ago?
Yeah, it's a great question. It overlaps greatly. There's a culture that I think Peter found in Michigan. Peter was at Hopkins when he did the actual MHA Keystone study, where it's very much about doing the best thing for the patient. It's not just a slogan, it's actually in the actual safety culture. And I have not found yet another state that actually does this as well as Michigan does, where I'm in conversations here with some of our payers to see if we can recreate this network as well. The overlaps are very simple, and I'll break it down to 2 domains. There's the technical things you have to do to actually make the right thing happen every single time. The technical things are the checklist, the technical things are the order sets, the technical things are using alcohol-based chlorhexidine when you place a line. Anyone can do it, it's not hard to do. Check the box, it's done. The harder things are what we call the social pieces, right? Check the line every day. Do you still need the line? If not, pull it out. What's the dressing look like? Is the dressing intact? If it's not intact, change it. Use less lumens, because now I'm telling you to make your decision based upon what I believe, not what you believe. That piece is really hard to do. And that's the piece that we actually haven't figured out yet, I think, in healthcare delivery. How do we take the social sciences, the things about hierarchy, about power, about culture that I referenced, to actually integrate that into the care that we deliver? It doesn't make sense that if you go to one UC Health hospital, you get device X, and you go to another one, you get device Y. Just think about it from a patient perspective. That part has been hard to sort of transpose. Michigan has done some of this. I don't think they've done enough. And I think nationally, this is a problem. This is why I'm delighted that anthropologists and social scientists are actually very much part of the healthcare infection prevention work that we do. They help us understand human behavior. How do you make the right thing to do, the easy thing to do every single time? That's the future I would like to see. We're not there yet, but we're working at it.
Dr. Chopra, thank you very much.
Thank you.